Okay, so good evening, everyone. Thank you for joining the meeting. Um, this evening, I'm going to present a case of a patient that I took to theater for a hysteroscopy. I will talk about the complication that I had for the case, and then hopefully we'll be able to have a discussion afterward. So I saw Ms. GT in December 2021. So this was after passing part one of the Gezia examinations, and I was feeling pretty confident. And so for most patients, I would just offer an endoscopic procedure. So she was a referral to me with a history of postmenopausal bleeding with a thickened endometrium that had been seen on a routine ultrasound scan that she had gone for, and the GP recommended that she come to me for a diagnostic dilatation and curettage. So this was a 58-year-old para 2 with having had one miscarriage. She delivered live babies in 1988 and 1992 by normal vaginal delivery, and in 1989 had a first trimester miscarriage and had a DNC done, a surgical management of that miscarriage. She had attained menopause at the age of 53, and she admitted to having mild, manageable postmenopausal symptoms, but she hadn't required any hormone replacement therapy and hadn't taken it. She also admitted to having yearly well woman checks. And from these checks, I established that in 2019, cervical smear had shown that she had atypical cells of undetermined significance. This PAP was repeated 6 months later in a different country, and she was told it was normal. In October of 2021, when she had gone for her well woman check that subsequently led to a referral, she had had a pap smear that showed ascus, and I think she had been advised by her GP to use yogurt PV to manage the ascus. So they hadn't done anything further about that pap smear result. She admitted to having used the combined oral contraceptives throughout her reproductive lifetime, with no plans that she had used as a last method of contraception. She said her mom's sister had succumbed to cervical cancer, but otherwise there was no family history of breast, uterine, ovarian, or colorectal cancer. In her past medical and surgical history, she had only had suturing of a gunshot wound. Sorry about the typo. Which was done in a casualty. She admitted to being hypertensive, but she wasn't taking any medication. She said she was using lifestyle management on agreement with her general practitioner. Of significance in her gynae history, she had attained menarche at age 13. I mentioned her age of menopause. Her periods had been regular, 4 to 5 days of bleeding with no period pain and no heavy menstrual bleeding. When I questioned her about the postmenopausal bleeding, she said she hadn't actually seen any bleeding, but before she had seen the GP for a well woman check in October, she had just had 2 episodes of cramping with passage of a brownish discharge. On examination, she was obese. She had a blood pressure of 133 on 83. Her abdominal examination was not significant. I didn't palpate any masses. Her cervix was normal, and I thought she was relatively estrogenized for her age. She came in with her scan from the GP that showed a diffusely thickened endometrium, uterus with those dimensions, normal ovaries from the scan. So at the end, my problem list was I was dealing with a postmenopausal woman with a thickened endometrium and with a recent pap smear result that showed ascus. So in planning to do the endometrial sampling, I did a swab for high risk HPV following the ASCCP guidelines, and this high risk HPV was not detected, so she can go back to a routine cervical screening. And we had a discussion about the best options for sampling. So I did offer office sampling. I don't have office PPLs, but I did put it to her that we could sample within the office. I did speak about the diagnostic DNC that her GP had recommended that she have. Obviously, thinking that I was coming out of the cave, I put it to her that this was a blind procedure, likely we wouldn't really be able to, it would be better to do a hysteroscopy because we'd have good vision of her endometrium and do targeted biopsy rather than blind biopsy. And funny enough, during that conversation, I said during a DNC, there is a high risk of perforation, but I may have omitted to mention that it is also a risk with hysteroscopy. So we went on to do the diagnostic hysteroscopy that I had sold to her. And this was what we saw, an atrophic endometrium and what looked like a submucosal fibroid in the posterior wall of the uterus. So we then, given that we had seen that she had something that looked like a fibroid, we then decided to go on and do an operative hysteroscopy. Sorry, I omitted to mention that before the diagnostic hysteroscopy, I had given her misoprostol with analgesia to ripen her cervix. Therefore, the diagnostic hysteroscopy went ahead without a problem. When it got to the time to do the operative hysteroscopy, we realized we needed to dilate her cervix better. So we used we used Hager dilators to dilate her cervix. And I will talk about this picture and come back to the problem. Yeah, okay, this is a video. Can you see anything?
There's nothing yet.
There's nothing yet. Okay.
Yeah, there's nothing.
It seems the one I uploaded, right. The one I uploaded is not working. Let's see if it plays, if it's not in slideshare. Nothing is happening. Okay. I have a backup. Please give me one moment. Okay. Just 1 second. I'm now looking for the presentation. Let's hope this works. Can you see something? Okay. So you can ignore the background chatter. I think I tried to mute this. let me just put back the presentation, if I can find it. So, okay. So actually, so what happened? Can you see my slides?
Yes, we can.
We can see.
Okay. All right. So for those who hear Shona, you know that we had thought there was a problem, and indeed there was. So after the diagnostic hysteroscopy, I mentioned that we needed to dilate the cervix. So we did dilate using Hager dilators. So at one point, I was working with my mentor, who then corrected the way I was holding the Hager dilator. So the perforation could have happened when I wasn't holding it properly. You know, when you put your index finger and you sort of use that as a stop to preventing your further entrance into the uterine cavity. I wasn't doing that, and he showed me how to hold the Hager dilator properly. Now, I'm not sure whether this is something that comes from working with a mentor, and I'm not sure why I didn't know how to hold a Hager dilator like this, but that was the first problem. The second is when we thought we had dilated enough, when we put in the operative hysteroscope, we used a little bit of force. So that is when the perforation could have happened. It's not very clear from the video, but if you see where my laser pointer is, we could see a little bit of bleeding from there. And I work with a mentor who is very careful. So he said, look, there's some bleeding over there. Then if from the conversation, I was trying to say, it doesn't seem like it's a lot. Plus, in any case, it seems to have stopped. But in any case, when we then managed to remove the specimens, he kept saying, I really think this is a perforation. And so this is straight after part one. This is my first private hysteroscopy patient, and I seem to have perforated. So unbelievably, we then decided, okay, let's go on to do a diagnostic laparoscopy. A general surgeon happened to be waiting in theater to do a case with my mentor, and we actually asked him to come in and to help us to inspect the bowel. To my horror, because I'm thinking, I mean, at this point, I was actually paralyzed because I was thinking, I don't think I gave enough pre-op counseling. Oh, I have perforated, yet I sold this procedure. Oh, we're actually doing a diagnostic laparoscopy. She's going to wake up with umbilical ports and, you know, the accessory ports for suturing. What am I going to tell her? So, yeah. The perforation was enough to humble me. So you can see it was a beautiful looking obvious perforation on the anterior aspect of the uterus. There wasn't a lot of bleeding, to be honest. We went on to repair the perforation. So my mentor did say, since you were taught how to suture in part one, go ahead and suture, but I was now in no position to suture. I normally handle stress very well, but at this point, I think adding to my horror was I was at this private hospital for the first time. Case had been booked under my name, and you have a perforation. It's your first case, and you are needing to suture. So I couldn't even calm myself enough to repair it. Anyway, the slight bleeding stopped with the one suture, and we cleaned up. I waited for her to wake up. I think I went back to the hospital in the afternoon after she had woken up, and I disclosed the fact that we had perforated and that we had repaired, and she wouldn't be going back home that day. That, as I had promised, we would watch her overnight, and then she would have to go home the next day. But to my surprise, she was quite philosophical about it. She wasn't angry or emotional. She just said, no, I know I'm in good hands. So it's okay. It's happened. It's fine. You say, I'm fine. You're watching me overnight and I'll go home tomorrow. And I said, yes. And so actually, the rest of her hospital stay was fine. I discharged her the next morning and I saw her a week later for review. She had no issues at this point besides some post-op nausea, which she had stopped after she had stopped taking her stop pain, which was one of the analgesics that I prescribed for her. She was seeing minimal, when I examined her, she had minimal blood within the vagina. There was no cervical excitation, tenderness. The histology results were not ready. I asked her to continue betadine paints on her abdominal wounds from the laparoscopy. And remember, I mentioned that she was obese, so we spoke about personal training and weight loss program. And here I say, then she tells me the real story. Then she tells me she's related to some, she's the daughter of a Liberation War hero. And I'm thinking, so if anything had gone bad, I would have actually been in jail. Perhaps, I don't know. At least I'm glad she had withheld this information from me before we went to theater. But anyhow, at 36, she was well. She was already back at work and all her port sites had healed. And I sent her back to her GP to continue managing her hypertension. The histology came back. I think we discussed this at her 6-week review. And it concluded that it was indeed a fibroid, a submucosal leiomyoma. So that's the end of the case presentation. I don't know whether there are any comments. I think I just have a few slides.
From everyone, anyone? Okay, let me start. Let me get the ball rolling. Thank you very much, Dr. Gwanzura. Well done. This is what happens. I don't know, you remember I talked about this. You are now, as you said, confident. Now I have to take ownership of the complications. And the issue is that everyone makes errors. And you didn't set out to make that mistake. And although you have been taught all of this, what then happens is that always the being aware during the process. You have been taught theory, you have been taught this, but it's only when you start practicing, that's when you truly learn. So we don't set out to make mistakes, but that's how life it is, and that's how we learn. And the other issue is also, it's not about making the mistakes. It's how you learn from your mistakes that counts. So I am sure that as going forward, we all learn and improve and become more acutely aware. Because one of the biggest things I had a case as a registrar where I had an intern and I told him, the most difficult operation you can ever do is a DDNC. For me, it's the most difficult surgery. So I told him to do incomplete, the evacuations first, and then call me when it was time to do the DNC. So unfortunately, he chose to do otherwise. And the anesthetist registrar called me and said, I think your intern needs you now because he's looking at bowel through the vagina. So obviously he never became a gynecologist after that. So all I'm trying to I had to do the whole thing. But I think I'm happy the case was resolved properly, because one of the worrying parts of using energy, especially monopolar, that one of the things that I'm a bit worried about bowel injury. And the question is whether you put the person on antibiotics and in terms of checking that there's no, indirect thermal injury on the bowel. That's the only thing that I'll be more worried about. But otherwise, I think that's how we learn, and you did very well. And obviously, one of the things that I remember, I had a patient who also told me the same story, that, if anything had gone wrong, number one would be at my funeral, and then you just freeze. Yeah, that kind of thing. So don't worry, that's life. I don't know if does anyone have anything to say?
Thank you, Dr. Abuma. I saw Stanley's hand.
Hi, thanks for the presentation, and thanks for well done for fixing this complication, and thanks for the comment by Dr. Abuma. My comment maybe will bring you back to the beginning as to if someone is having post-menopause with a routine scan showing a thickened endometrium, what is the best way to assess that endometrium? Is it automatic endometrial sampling, or I don't know, is there any, is that what we should be doing? I don't know.
So I discussed this issue with my mentor, and I think others can comment as well. For this particular patient, there was this question of there are symptoms. The referring GP said bleeding, although she told me she had a brownish discharge. And then she has this routine scan that is showing a thickened endometrium. So in this instance, she's had a scan and she has symptoms. Therefore, that's an indication for sampling. Whereas if you are doing routine scans and you come across a thickened endometrium and there are no risk factors, I believe, for endometrial cancer, then there is no need to sample the endometrium. I think this was my understanding from a conversation I had with my mentor. But everyone, feel free to let us know your thoughts.
Can I just?
Okay. So, yeah. So the other thing, Chibo, that I wanted to also bring to your attention is that when a GP refers to you for a procedure that you don't agree with, as a consultant, you're actually free to actually reverse that decision and give your evidence-based assessment. So you don't really need, you're not obliged. If someone says you should go for a DNC, you should sit down and say if you actually assess if there's need for or not. Not that I'm saying there's no need in that particular case. I'm just saying in future reference, there's no need for you to actually emphasize that the GP had referred for DNC and this and what. If you saw her and you thought that she had postmenopausal bleeding, or she had symptoms postmenopause, or she had other risk factors that warranted you to do a sampling because she had 8 millimeter endometrium, and then you should actually state that, not that the GP had sent for this and this and this. I've been referred so many patients by GP for some certain procedure that I actually say maybe at this particular time we actually don't need that procedure. Maybe they go to other specialist and do the.
So I agree with you, Stanley. I usually make.
From my understanding, if there's evidence saying you don't need.
Well, I totally agree with you. I totally agree with you. But you know, this thing of coming out of the cave. So my justification at that time was she does have the brownish discharge, so she has old blood and the thickened endometrium, and I badly wanted to do a hysteroscopy, which is why I was feeling extra bad. Taku.
Thank you for the presentation, Chipo. One thing that I just wanted to check in with is when a patient comes through, for this particular patient, for an obese patient, was this a transvaginal scan? Was it a good scan before proceeding based on it?
Yes, it was. Sorry, I didn't mention. Yes, it was a transvaginal scan. Done by someone I think does good transvaginal scans.
Okay, that's the reason why I'm asking.
Yes, Tagu. Hello? Can you guys hear me?
Yes, I can hear you.
Okay. I think Taku was still speaking. I missed if she said anything in the end.
Yeah.
Sorry,
but,
I had a power cut. I'm not sure if you can hear me.
Yes, we can hear you now.
Right. What I had said was I get it that scans can be a little bit inconsistent, but the diffusely thickened 8 millimeter endometrium and the submucosal fibroid are not exactly in keeping. That's why I had asked.
Okay. Okay.
Doctor, can I just also comment? I think for me, overall, the management was correct. I mean, the decision-making process to say, obviously, there was a thickened endometrium, there was an incidence of bleeding, and she's also on the obese side. So obviously, in terms of risk factors for endometrial CA is also a bit high. Especially, obviously, you said she was well estrogenized for her age. So you're talking about estrogen. So she makes, from the fat, she makes E3, not E2. So that's extragenous source of estrogen. So she is at high risk of endometrial CA. And I also concur that the only valid is visual. Yes, all the other indirect ultrasound, the MRI scan, all the other indirect measures will also not be as conclusive as the hysteroscopy. And as you saw there, it was more like a focal lesion. So definitely nothing would have been prepared you for that. But I think on the whole, I think in terms of anyone who presents with symptoms, I think it is better to do hysteroscopy.
Thank you, Taku, Stanley, and Dr. Bvuma. Lefilihle, you have your hand up. I think you need to unmute.
Is there any more comments?
Yes,
Dr.
can I? Oh.
Please go ahead. Felix, I think you had unmuted. Is it my network?
No, I don't think it's your network. I think it's their network.
You can hear me. Okay.
We can hear you, but we can't hear them. But my yes. Can you hear me?
Yes, I can hear you.
If a salary field sonograph was going to make any difference in this patient, I'm not really. I don't know if she was really bleeding because you said there was no history of bleeding. Okay, so let's say suppose there was no bleeding. Were we no bleeding, and she's having 8 millimeter endometrium?
Then I don't think she's if she wasn't bleeding, with an 8 millimeter thickened endometrium, then I don't think she would have been a candidate for hysteroscopy. But to my mind, she admitted to having 2 episodes of cramping with brownish discharge, and I took that to be old blood. I think it was a bit aggressive, but yes.
Well, yeah, my mic is unmuted. Can I come in there, Chipo?
Yes.
Yes, sorry about that. I was struggling to unmute. My name is Ali Murudu. If you guys don't know me, I think I know a few guys in the group. First, I would just like to mention that well done the case was managed well according to my understanding. The important thing about doing any form of surgery is to be able to recognize complications early and to be able to manage them appropriately, of which in this case you came out tops because the complication was recognized intra-op and it was managed still minimally invasive on the same setting, and that's the best thing that you could ever have done for the patient in this regard. Now, to add to what Dr. Vuma was saying, in this regard, the gold standard for any form of endometrial sampling, even now we also moving it towards management of miscarriages, is hysteroscopy, because that's where you have the best vision in order not to be just curating or trying to sample all over the place, not actually knowing what you're sampling. You actually minimize damage to the actual endometrium, particularly in reproductive age women, by actually going to remove whatever remnants of pregnancy that are remaining directly where they are. That's just in general when talking about miscarriages. But for this kind of case, as Dr. Vuma has mentioned, you would have unlikely came out with much if you had just sampled blindly without actually knowing where exactly the problem was, which that's why hysteroscopy is the gold standard for management of these cases. Now, in terms of saying if she didn't have symptoms and you pick up a thickened endometrium, a 58-year-old postmenopausal with a BMI of 41, that on its own, it should raise suspicion to say that if you have this kind of thickened endometrium, even if she hadn't complained about it, but you found it on incidentally on scanning, that would be a good ground for you to say that I should actually go in and have a look and see what is causing this thickening. Because if you are just going to say because she doesn't have symptoms, then she must go away, you could be missing endometrial hyperplasia and or endometrial cancer. So I wouldn't think that with a lady postmenopausal with a BMI of 41, you just want to say it's a thickened endometrium, she doesn't have symptoms, then go home, come back when you have symptoms, because that could actually be detrimental to her. She might come back with endometrial CA that you could have managed early in her presentation. Thank you.
Thank you, Ali. Felix, you wanted to say something before you dropped off the call. And Stanley, I hope you are answered in terms of the saline infusion sonography.
Sorry, I had to go out of meeting. I'm listening from my phone, so I didn't get that information on saline infusion. I was off, but I got the last point, which I actually agree with him that so this is a point that I was trying to say, that if you have got risk factors, a thickened endometrium, yes, that's a reason to actually do the sampling. But now the sampling, because the other question was now you're offering to do a PPL or a Vabra. That's what I was going to also ask, if that was the correct thing. So I think the correct thing was to, if you see someone with those risks, a hysteroscope where you actually see and actually do a diagnostic for that. I don't know what was said about the saline infusion sonograph. If I can get that one, just a summary.
I think it was an indirect answer to say the gold standard is hysteroscopy, particularly for this patient. I think with the same sort of explanation that you have given, that she has risk factors.
No, but
so in your view, if a woman has risk factors, you wouldn't PPL her?
I think
it has 85% pickup. I was just selling the endoscopic procedure, but isn't the literature that it is a fairly good screen, though I doubt it would have been able to get a sample of that fibroid.
So I think for a generalized diffuse, I don't know what they meant by diffuse, but if you've got a generalized endometrium that is sick, then you can use a PPL. But if you have got a focal point, in this case, the transvaginal ultrasound scan is supposed to pick that there was really one focal thickened area where we see that fibroid. So I think with saline infusion, you're able to actually see that there is this mass which is in between, and then this endometrium is thick this side, and this thick this side, then you can actually add. I think that's what, so that when you go in, you actually know what you're going to do and what you're going to look for, instead of just going in blindly. I understand cystoscopy is still used, you have direct vision, but you still have to have an idea of what you're going to see when you go in. So that's why I would say maybe a further test with the transvaginal saline infusion sonography, you would actually see that there is actually a focused mass that can actually be differentiated either as a polyp or a fibroid by the scan.
Do you do it yourself, Stanley, or do you refer?
Currently, I'm referring, but I would love to do it. So some of the transvaginal I do myself, but this saline infusion, I don't have the catheter at the moment.
Please go ahead, Ali and Taku.
Oh, I forgot to put my hand down. But
okay.
Remember, hysteroscopy does not necessarily have to be done in theater. So in some instances, you find that people have office hysteroscopy. So as much as you can do saline infusion ultrasonography, you can simply pop in a scope with a simple analgesia, and on the same setting, then the patient goes home. So I do agree that you can do saline infusion hysteroscopy, but none of the two are incorrect in this case, if I may put it that way.
Taku.
May I go ahead?
Yes, sure.
Right. So I think the part that I wanted to contribute to was saying the counseling, because now we're implying that I think the way you ask the question is as if you were supposed to present one option for going forward to the patient, and I don't think that's ideal. So ideally, you should give the patient enough information to make an informed decision. If you look online and you check the consent forms, normally you'll find that there's a section where the patient signs that they've been given other options before a procedure is done or before an operation is done. So the idea is to say, we could do endometrial sampling. These are the advantages, these are the disadvantages. We can do hysteroscopy. These are the advantages, these are the disadvantages. And then allow, of course, as we speak, most of us have bias, but the art is supposed to be able to give unbiased information and allow your patient to make an informed decision, even if it's not what you personally lean towards, unless you're asked what you personally lean towards. So you should know the stats and give the patient adequate information to make an informed decision.
Thank you for that, Taku. And I think it was a very important lesson that I learned after doing this case. Because for me, to be honest, I was selling endoscopic procedures. I did put her other options on the table, but if you were listening to me, you would have bought endoscopy, and she did.
So perhaps one thing that I would suggest is if we can work on a consent form that's specific for hysteroscopy, where we actually list the alternatives to hysteroscopy, and then we're sort of presenting to our patients a more objective way for them to make a decision about how they want to go forward, should we find that they have certain risk factors or certain incidental findings.
Yeah, Taku, can I come in there? If just to ask, if in terms of the options that we had with this patient, because I think the important thing for her was to get histology and to at least allay her fears that it's not cancer. That's one. Two would be to resolve the symptoms that she presented with. And in this case, there are three methods that could be put to her, unless if I've forgotten about one, you guys will remind me. It would mean that she would either get what we normally call a PPL, the Z sample, which it's easier and less risk of perforation and stuff. The other option would be to go blindly with a curette and do a DDNC, which is highly likely because you still have to dilate the cervix, you still have to put in a curette. That in itself also poses a risk of perforation. But and hysteroscopy, with which compared to a blind DNC would be less, you are less likely to perforate if you do manage to hydrodilate rather than to dilate with a Heger dilate. I think that is another point that we should bring up, to say that if you feel that the cervix is maybe perhaps stenosed a bit or is still tight, you can ripen it slightly overnight, and then rather than to dilate with Heger dilator or anything, you hydrodilate. Basically, you go into the vagina with the fluid running, and then you go into the posterior fornix, then you pull back until you see the cervical os. Then you approach the cervical os slowly with the hysteroscope. As the water comes in, it tends to dilate on its own rather than to try and dilate it mechanically. I think that could be something that helps. I especially in an office setting and as well as in theater, I've noticed that hydrodilation, as much as it might take a bit of time to dilate and open up, but it does work better and it minimizes the risk of perforation while trying to dilate the cervix.
Well, that's interesting. I've not heard of hydrodilation before. Thank you.
Is
Does
there
anyone-
a difference between what is referring to as hydrodilation and vaginoscopy? Because the idea is you do the vaginoscopy, right? Is there a difference between what he's saying in terms of hydrodilation and vaginoscopy?
It's the same thing, because basically that's why I'm saying you go into the vagina with the fluid open, then you go into the posterior fornix, the vagina is filling up with water, then you pull it back slightly, then you should be able to see the cervical os. And then you just approach the cervical os with your scope with the water open, and you gently try and proceed as it dilates. So it's basically vaginoscopy, then it dilates. So that can be done on both settings, in office and as well as in theater.
Okay, I just wanted to clarify for Chipo that it's more the use of words, but it's essentially vaginoscopy.
Okay.
Chipo.
Yes,
Hello?
Stanley. Yes.
Yeah, I wanted to find.
Please go ahead.
I wanted to find out, in this case, were you checking the fluid deficient balance, the fluid that you put in and out, or before you wait for bleeding to see that there's perforation?
I want. So when we went for an attachment at a fertility center in Johannesburg, we realized that there's a dedicated person managing the fluids that you use at hysteroscopy. So, and it's really clear how much has gone in and how much has gone out, and whether there's a deficit or not. At the hospital we were at, which is one of the two best in my view, in the private setting for doing a hysteroscopy at, there is a person monitoring, but yeah, no. So the short answer to your question, Stanley, is no.
Hello. If I can add, Calstots, which used to have that fluid monitoring system where the input fluid going in and fluid going out and the pressures and everything, they've actually withdrawn their machines worldwide because there was obviously an issue with their calibration of the machine. So there's no longer any that intelligent fluid management system available. So I think most of the time you look and just have an estimate of what is spilling, what is whatever, because there's no longer that luxury that we used to have before. So there's nothing that you can use now. From what I don't know about the other companies, but for the one that we used to use from Calstots has been withdrawn. I think it's about time. Is it about time, Dr. Think?
It is about time. I think it's not necessary for me to go into the statistics since Dr. Myocha had a detailed presentation about this. After the gloomy presentation, I wanted to talk about the happy ending. I always focus on the good. At the point I made the presentation, I think I was in between the practical and my exam, that we are moving on, trying to get out of the cave. But I keep learning so many lessons. During that week, we were doing another hysteroscopic procedure, and we were switching from the diagnostic hysteroscope to the operative hysteroscope, and I removed the light source in preparation to put it onto the operative scope, but then there was a little bit of debate about the operative scope, and I left it on the sheet. I didn't indicate to put the light on standby. And the next thing I saw when I glanced at the patient was smoke coming from the towel. The light source burnt right through the towel, and my patient got scalded. So that was another lesson. You know what Clive keeps saying at the Gezia Training Center, put your light source on standby. So now I'm practicing that religiously. I was doing that when I went for the preparation for the exam. This particular patient actually sent her sister to me. The sister ended up coming to me when she was referred to a gynecologist for fibroid uterus, which was roundabout the right size for attempting Dr. Shawa's what is this, the vagist, where we use the myoma screw. But unfortunately, I think we were not well prepared. We didn't, the hospital assured us that they had the smaller myoma screws, but they were not available at the time of the case. We ended up converting that vagist to an abdominal hysterectomy. And that afternoon, I again had to go to the sister of that patient to say, but at least I think my counseling was better this time around. I did say if the vagis doesn't work, we may need to resort to laparoscopic or an open procedure, but she wasn't keen on laparoscopy. So my concluding remarks are, I'm still trying to get out of the cave despite everything still. So I don't know whether there are any announcements for next week. The lesson still continues, and I think it's exactly 7. Dr. Vuma, I hand to you.
Yes, I'll just conclude this note. I think, in my view, you did well. And one of the things is that as you move from being a novice to become a master surgeon, complications will come. And I think this is how you manage the complications, and emotionally how you recover. We will all have to deal with and look at the patient in the eye and tell them it didn't work out the way. I had the opportunity to meet Dr. Redwine, who is the guru of endometriosis in the US. And because I asked him over all these years, how did you manage to do so much endometriosis, stage 4 endometriosis using monopolar, and you never had any complications? And he says one of his lessons was always talk to your patient. Always don't break that communication. Whether the things go wrong, always keep communicating with your patient. And I think to finish off, a surgeon knows how to operate. A good surgeon knows when to operate. A really good surgeon knows when not to operate. So you should then be able to use judgment and restraint. And I think our duty of care must override our wish to intervene or operate at any time. But I'm glad that at least you are getting out of the cave. Complications will happen. It's part of the journey. You cannot be an expert without having complications. On that note, I think we can call it a day, and then hopefully we'll meet again next week.
Thank you, Dr. Bumain. Thank you, everyone, for joining.
Thank you. Good night.
Bye.
Thank you. Goodbye.